Hello everyone, this is Julie and I'm back again with Unit 7, Childhood and Neurodevelopmental Disorders. And then I'm also in this lecture, make it one video, it shouldn't be too long, touch on impulse control disorders. They are both our content from Unit 7. I will have suicide separately because it is switching units in different quarters. Risk factors for childhood and developmental disorders, genetics. 20% of children and adolescents in the US suffer from a psychiatric disorder that causes impairments. Hereditary factors are implicated in so many different childhood disorders. So we have to be mindful of that. We do have some neurobiological changes in the brain, low emotional regulation, and then temperament. Temperament is a big one: attitude, mood, behavior, how we cope with demands of the environment. When we look at the temperament, we want the child's temperament and the parents to kind of mesh together. If we have a parent who is like super rigid and the child's more lax or vice versa, it can cause some kind of disruption between the two. Attachment we talked about when we talked about trauma. If we do have differing temperaments, we can see struggles to form attachments. Maybe the parent is not attaching to the kid as well as they did a different kid. And temperaments can be a big predictor. If we have someone who has very high anxiety when they're younger, it tends to carry over as they get older. So resilience, again, is a big one. It does not mean we're not affected. It's kind of those strengths, how we can handle events, and that ability to bounce back. We can see a whole bunch of traits that our resilient children have. It is much easier to develop, teach, and kind of refine resilience in a child than an adult. So we have to be working with our children. Risk factors, environment. We have talked so much about adverse childhood experiences. We can see, right, 60% of the population have one. People with 6 or more ACEs can die 20 years earlier than those who have none. 1/8 of the population has more than 4. We have talked about these a lot. If parents are abusive, rejecting, overly controlling, the child may suffer the detrimental effects at the different developmental points in which the trauma is occurring, right? So trauma and trust versus mistrust leads to some of those attachment disorders. We also have to look at different risk factors within the family. Parents who are fighting, low socioeconomic status. Parents, especially the mother, having a psychiatric disorder. Is the child in foster care, right? Neglect. Neglect is the most prevalent form of child abuse in the US. Witnessing violence. So many different things. When we talk about culture, I don't even know where to start. Differences in cultural expectations, right, along with the presence of stressors, lack of support within the culture, can have profound effect on children and adolescents. Many cultures do not openly talk about or address mental health. We have to consider that. As we are assessing the child, and some of this is again redundant, we have to interview the child and the parent, and then the child and parent together. How does that parent interact with that child? That is a big consideration. How does the child interact with the parent? We can get sources, we often call it collateral information, from many different people: siblings, teachers, youth group leader at church, right? All sorts of different environments. We would love it, perfect world, what the parents are saying and what the child or what the teacher is saying. If we give the Vanderbilt assessment is one that's used for kids, ADHD, autism, some of our impulse control disorders even. If the parent answers it in one way and the teacher answers it, we want them to mirror each other. That is not always the case. Developmental assessment provides information about that maturational level, what are the strengths deficits of the child. We more just need to know that abnormal findings in development can be related to stress or adjustment or a more serious disorder. In PEDS, you'll go more into that developmental assessment. The mental status exam is very similar to that of an adult. The big difference is we may have to look at our wording, the capabilities, the verbal skills of a child. We have a bunch of different types of therapy. Some differences between kids and adults. Play therapy allows the child to express anxiety, self-doubt, fear through natural play. Bibliotherapy are books. Um, they can gain insight into feelings and behaviors and learn how to cope through a story. And usually stories appeal to kids. Some of these are kind of the same in adults. Family therapy is going to be one of the ones that's a little different because pediatric patients are part of a family and they can't really be removed from their family. It is extremely helpful. It is a key component to have family counseling as part of the treatment. Um, Interventions, when we look at it, again, most of these are very similar to an adult. Teenage girls are honestly one of your most dangerous patients in a psych facility. So we have to be on the lookout. We have to consider safety above all else. Least restrictive first. I want to try to de-escalate. I want to try to talk. I want to try to remove stimuli, distract, provide some type of other activity to do versus going straight to seclusion or restraint. Communication disorders are deficit in language skills that cause impairments in academic, socialization, self-care. We have a few different areas we're just going to go over simply. A receptive language disorder, you have difficulty understanding or following directions. A child with a receptive language disorder might not be able to understand multi-step directions. I need to go and have you get your socks and put your shoes on and grab your backpack so we can go to school. That's a lot of different things in one sentence. We might have to tell the child, okay, go get socks. And then once they get socks, okay, let's get shoes and break it down for them. Expressive language disorders, difficulty finding the right words, forming sentences. Maybe they're not using coherent sentences. Maybe they are stuttering. Social communication disorder are that verbal and nonverbal and how we interact socially, right? In America, we have a lot of small talk. Hey, how are you? That we say, when we greet someone. This might be an individual who struggles with that pragmatic language. Developmental coordination disorder is just what it sounds like. Motor skill development. There are certain milestones in which we would expect a kid to be able to stand on 2 feet, jump off the ground, and then land back on 2 feet, or throw a ball or dribble a ball so many times while moving. This child is not meeting those milestones. So tic disorders is one of the first ones we're going to talk about. This is repetitive, purposeless movements, hand waving, rocking. I mean, it could be so many different things. Nail biting, teeth grinding. We tend to see this a lot more in boys than girls. Tics, sudden, non-rhythmic, rapid motor movements. It can involve multiple parts of the body. Vocal tics are spontaneous words, grunts, coughs, sniffs, barks. It could be very much. Tic disorders will start before the age of 18, but mostly in that kindergarten age. As we are starting kindergarten is when we tend to see them, and they will kind of progress. They can get better as we go into adulthood. However, there is a big risk of low self-esteem. The kids know you can't hide the tics. So the kids know that everyone knows what is going on. So Tourette's disorder is a specific disorder that is characterized by multiple motor tics and at least one vocal tic for more than 1 year. They all occur between the age of 18, and again, they start between 4 and 6. We talked in class that characterization of Tourette's that we see in Hollywood of someone yelling out obscenities. That does not occur in many cases. Most of the time, it is minor. I say minor, it could vary in severity. And it's hard because the tics can change over time, and what the tics are can vary. So people sometimes will call them out or be like, you're faking it. We do have some treatments that we can use, some therapies, some deep brain stabilization, some medications, but it will vary depending on the patient and what else is going on. These do often occur with OCD and ADHD, so we need to be cautious when we're giving medications. When we talk about stimulants, your Adderall, your Ritalin, Vyvanse will make Tourette's worse. So we don't want to start this patient. If they have ADHD and Tourette's co-occurring, we don't want to start them on a stimulant. In class, we talked about people who have Tourette's and we don't always know it. So I know most of y'all were like, what? Billie Eilish. She has Tourette's. She's had Tourette's. She doesn't often kind of talk about it because of it. I know most of y'all did not know this is Tim Howard. He is he retired professional soccer goalie. And he kind of struggled a lot when he was growing up, thinking, I can't do stuff because of his Tourette's. He also has OCD too. But then once he got into playing soccer, he was very outspoken. But as a child, will I have friends? Will I date? Will people like me? Are very big concerns that we see in children who have this disorder. Going fast, y'all. Learning disorders. Learning disorders, we tend to see these identified during school years. Um, when children repeatedly have trouble in a certain area, hopefully we are investigating. So if we have a persistent difficulty in reading, that is called dyslexia. Difficulty in math, dyscalculia, and then difficulty with writing is dysgraphia. Usually we're going to do multiple assessments of formal psychological evaluation, and then hopefully we can get the child some extra help within school. Intellectual disability, deficits in intellectual functioning, social functioning, and daily functioning. Oftentimes we tend to think, hey, low IQ, but again, we cannot look at the number. We have to look at the child. If we have something who does very well in like daily functioning, they can do age-appropriate activities, they can do self-care, maybe they hold down a simple job, it's going to be a little bit different than how I would treat someone who is just struggling in, social functioning or intellectual functioning. So we have to tailor what is happening to these children. Autism spectrum disorder is one you'll generally tend to know about. There's a lot out there on it. It's a complex neurobiological developmental disability that typically appears during the first 3 years. These used to be called pervasive developmental disorders because it affects so many different areas of the child's life. We can see our DSM criteria here. We're going to have kids who are not responding to their name, not making eye contact, not having the same social interest as peers. They might be parallel playing longer than we would expect, right? Parallel plays should not exist by like first, second, third grade, but maybe this child is still only engaging in parallel play. They might not be comforted or have the same interest as a normal child. So many different things can be included under autism. So when we look at it, we have to assess those developmental delays, loss of acquired abilities, kind of looking at what is going on with the child. Look at their communication skills, verbal, nonverbal, and social skills. Look at the parent-child relationship, assess the physical, right? Kids who are different. Kids who have some of these developmental disorders are at high risk of abuse. Look at the community programs that we can put the patient into, because early intervention is key. So we're in Texas. The state of Texas has early childhood intervention, and most states will have some form of it, where kids can be evaluated kind of from birth to 3, and they'll come to your home to do the evaluation. If your child meets the criteria for one of these, they can go ahead and provide services through the child in the home. At 3, it transitions into the school. So though Texas does not have preschool, if we have a child with one of these developmental delays, they can receive services starting at 3 into a school-based preschool. That multidisciplinary team can be huge depending on the child. Who can we have? OT, speech, feeding therapy, psychologists, neurologists, like family practice, psychiatry, therapists. So it could be a wide variety depending on what is specifically going on with that child. We do have to identify the areas where they are struggling and kind of form a plan for how we can work, but we also have to look at those strengths. What is this child good at, and maybe feed to their strengths, because if we only focus on the negative, that kid will never get there. But if we have a child and it's safety type behaviors, or they're not eating, very much food, we have some diet restrictions sometimes with autism, those have to be addressed. Meds, again, are too widespread to really talk about. Some of our second generation antipsychotics are great. Some of our SSRIs are great. Some of our stimulant, non-stimulant can be helpful depending on what is going on. When we talk about evaluation and what demonstrates success, our main priority in autism is safety. Um, these children don't always quite have a good idea about what is safe. So we do want to keep the kids safe, free from accidental injury. Um, and again, it's going to be tailored to each individual child. We did look, we have a few different levels of autism. Level 1 requires the least amount of support, with level 3 requiring the most amount of support. Level 3, we could see nonverbal, some of our severe deficits. So what our outcome would be for someone with level 3 is going to be much different than our outcomes for someone with level 1. ADHD. ADHD, attention deficit hyperactivity disorder. Um, I know it says ADD on here, but we don't use ADD on its own too much. What we tend to see is ADHD with inattention, ADHD with hyperactivity, or ADHD combined type. So ADHD with inattention, we tend to see more in females. They are sitting still, but they're not paying attention. ADHD with hyperactivity, we tend to see more in boys. They cannot stay in one spot. These kids are moving around and they are all over the place. Combined type, we are moving all over the place and we are struggling to pay attention. We do want to see symptoms present in at least 2 settings. If the teacher's like, no, they're super calm, they're paying attention, they're doing great in school, but they're struggling at home, we want to kind of figure out what is the difference between school and home. These kids can get frustrated easily. Their mood can be all over the place. School performance can struggle. If we're not kind of addressing this appropriately, they might get in trouble a lot. I know I've seen it in my kids' classroom and it always makes me upset. The teacher's like, you can go do X, Y, and Z when you are sitting still on the carpet. Well, my kid with ADHD hyperactivity, he has combined type, but he very much cannot sit still. When you say you have to sit still to get this kind of reward or activity, we are inadvertently punishing the kids who are struggling to sit still. So we have to kind of look at all of that because that will affect their self-esteem. These kids also may struggle to make friends because the kids don't always think positively about themselves. We do want the family engaged in therapy. We need a consistent type environment, a pattern, picture charts, graphs kind of about what is happening. And we want to try to reach normal development. But again, normal is going to be different for each and every kid. When we talk about ADHD, we do have some medications that we can use. Our stimulant medications are wonderful. Um, Overall, the goal is any kid on ADHD we want on a stimulant. They're very sometimes sudden changes. You give that first dose or two of the medication, and with that one pill, you can see a change. The child can sit still. They're a little bit more focused on the task, less distracted. However, they are stimulants. So this is, again, legalized meth. So when we talk about side effects, very similar to what we would expect in someone doing methamphetamines. They are not able to sleep, especially for giving medications later in the evening. Oftentimes after like 2 or 3 p.m., we don't want to give a dose. I think your textbook answer is 4 p.m. Some of the psychiatrists I worked with didn't even want a dose after 2 because taking a dose in the evening can keep that child from sleeping. Appetite and upset stomach are 2 that go hand in hand. And we tend to see a stunt in growth. We tend to see weight loss. So we do need to make sure we're monitoring their weight. Headaches are a big risk, as are increased risk for hypertension and tachycardia. So we do have to monitor. And surprisingly, it can also be called lethargy, where we're just kind of a little bit more sedate than we would expect. Non-stimulants are going to be our Strattera atomoxetine is the long name. If we have someone who has high anxiety, I might not want to give a stimulant. If I have someone using substances, I don't want to give a stimulant. If I have someone with a tic disorder, I don't want to give a stimulant because that stimulant is going to make the tics worse. Side effects, again, are very same. Upset stomach, weight loss, insomnia, increases in blood pressure, heart rate, fatigue. We can see an increase in suicidal ideation with our non-stimulants, and honestly with our stimulants too, if we have someone who is at risk. So how do I know a children is getting better? We got to look at each individual symptom, and we've talked about a lot of different things. What I'm going to look at for ADHD is different from what I'm going to look with autism, which is different than what I'm going to look at with dyscalculia, right? The difficulty with math. School performance, how they are doing with their friends, their social interactions at school is a really easy evaluation to look at with kids. Are they making progress? Safety is always going to be a priority. There's really good research out there on how stimulants decrease accidental deaths in those with ADHD, because that impulsivity that we tend to see in ADHD. Family understanding, does the family truly understand what these conditions are? You know, my parents are very anti Braxton has ADHD type stuff. Braxton does not have autism. And part of it, my dad's like, well, when I was a kid, we just called this ants in the pants and boys couldn't sit still. However, with Braxton, it is very much more that like driven by a motor, he cannot sit in one spot. Like he cannot sit at the dinner table for more than like 30 seconds. So we do have to look at kind of the family's thoughts and how the family is working through this, depending on what the diagnosis is for that child. There are so many resources out there for kids, but oftentimes the families don't know where to find them. So being able to link families to different resources out there. Texas still has an ongoing grant where they are giving, families, kids who are in SPED, bonus if you have a medically compromised kid too, $1,500 to $3,000 to use for educational expenses, therapy, copays, different things like that. But most people don't know or haven't heard how to access this. So it is a wide variety. There are long wait times to get into some of these providers with kids. So we really need to kind of focus on it. Some videos that we have that are going on about these. Now we're going to go into impulse control disorders. This is kind of still in Unit 7. So impulse control, when we think about it, like impulse shopping is a kind of good one to segue into. If we think about this, if you're at the grocery store and they have something on that like end cap and you're like, ooh, I love this. This is a new flavor. I want to try it. And we impulsively buy something. That is the simplest when we talk about controlling impulses. In an impulse control disorder, this is someone who is unable to control those impulses, and we tend to see aggressive behaviors and emotions. How they deal with problems with other people's are not socially acceptable, and they tend to struggle with healthy relationships. We tend to see aggressive behavior, high rates of criminal justice system in individuals who have impulse control disorders. So oppositional defiant disorder is the first one we're going to talk about. These are individuals who are angry and irritable. They're not, right, and it's in the name. They're oppositional. They are defiant, especially towards authority. It does impact both emotions and behaviors. It does make it difficult for this child to attend school, have friends, right, be a member of the family. It could be in one setting, it could be in multiple settings. They're going to lose their temper, they're going to argue with family, they're going to blame others, they're going to get annoyed easily. They're not going to follow directions given by authority figures. They like large rewards but don't care about penalties. Untreated, children with ODD can grow out of it. It's not a guarantee, but they may. Some will always have social difficulties, problems with authorities, or academic problems. We can see some of these risk factors if we don't get along well with our kids or our parents, if we have a chaotic caregiving or a harsh, neglectful family. If parents who are being super strict and always putting the child down, lack of structure at home, right? Chaotic caregivers, low socioeconomic status, neighborhood violence, are all different things that we can see that cause this disorder to be developed. And I know some of y'all are always going to come at me and be like, well, they just kind of need behavior. However, we do see changes right to the brain. We see lower resting heart rate. is right, lower less resting heart rate is positively coordinated with an increase in aggression. We do see increased gray matter in the left temporal area, which is where we tend to see impulsivity. In boys, there are neurotransmitter and hormonal changes with serotonin, norepinephrine, dopamine, low cortisol, elevated testosterone. So it is not just psychosocial. There is also biological underpinnings to these. So treatment needs to be both for the child and the family. Anger management is a big one. If angry and irritable, let's get them into anger management. Let's talk about problem solving. Let's talk about parent training, how the parent is going to approach this kid. Group therapy, right? Cognitive behavioral therapy is always a good one. But again, we have to look at multiple different areas. Medications are going to be iffy based on what else is going on. Depakote is one. If the patient has a comorbid illness, ADHD, depression, anxiety, if we treat one, it could have an effect on the other. In class, I know we'll watch this video, and she was like, oh, the guidance counselor is a pumpkin butt, and she was just really just rude and disrespectful to the guidance counselor. She's not aggressive. She's not hurting anyone. She was just very angry, very irritable, not taking kind of responsibility for her part in it. That is very much that kind of classic ODD. Now, conduct disorder is a little bit different. In conduct disorder, we see persistent behaviors where the rights of others are violated. We are not following society's rules. We're not following society's norms. The behavior is extremely aggressive, fights, bullying, coercion, right, destruction of property, physical illness. This is a child disorder. Conduct disorder will be diagnosed in childhood and adolescent, and oftentimes when I worked with pediatric patients, the one question we would ask to kind of look at conduct disorder as a good red flag, do they hurt children? This is the kid who's putting the gerbil in the microwave because they want to see what happens, and they don't feel bad about the fact that they killed the family gerbil. Or they're going to sit on the family cat and squeeze it because they wanted to see what it looked like when the cat stopped breathing. And they will not feel bad about that. In it, we're violating the rights of others. They're initiating fights, coercion to include sexual coercion. They're going to crave excitement, but they do not care about the consequences. That emotional callousness, where they just don't feel bad, is a big red flag to the future. There is a big genetic component with conduct disorder, and we have to get the parents on board to treat it. But if the antisocial personality disorder is the grown-up version. So it is conduct disorder in those less than 18, and it is antisocial personality disorder in those over 18. If the parents have antisocial personality disorder or antisocial traits, they're not necessarily going to buy in or believe what is going on with their child. So this individual, very much danger, safety towards others is a big one we're going to consider. We do have two subsites, childhood and adolescent. Childhood is before the age of 10 and occurs mostly in males. They tend to be more physically aggressive, poor relationships, little concern for others. No guilt, no remorse. Adolescent onset, we're not really going to see symptoms until after age 10. Males are more likely to fight and vandalize, have school discipline problems. Girls are more likely to run away, abuse substances, engage in promiscuity. Kleptomania, pyromania are two things we may see under conduct disorder. I'm going to take stuff from you, right? Kleptomania, we're going to shoplift, we're going to steal stuff, and we don't feel bad about it. It's very impulsive kleptomania. And then pyromania, we're going to set fires, and we just don't feel bad about setting fires. We watched this video. He kind of thinks it's funny. A barn accidentally burned down, but they used a few gallons of gasoline. And then they put cement in a teacher's gas tank. Put cement in the teacher's gas tank in the car. And he thinks it's funny, and there's no remorse, no feeling bad about it. He violated rights. He violated the laws and rules of society, and he does not care. That tends to be what we see in conduct disorder. So when we compare the two, because it is important to know the difference, oppositional, conflict with authority, right? Negative mood, temper outbursts. If we don't treat it, we can grow out of it, right? We are angry and irritable with ODD. Conduct disorder, we do have conflict with authority in adults. However, it is more severe, right? Aggression, theft, destruction of property, right? Aggressiveness. We don't feel bad about it. Honestly, they can't feel bad. There's no ability to feel bad. If untreated, it will develop into antisocial personality disorder as an adult. And we will talk about antisocial when we get to our personality disorders, because antisocial personality is probably not what you're thinking it is. So, our last conduct disorder is intermittent explosive disorder. And I know there's a lot here. These are behavioral outbursts, inability to control that aggressive impulse. Verbal, physical, can be targeted towards other people, animals, property, themselves. Anything can trigger it, and it can be something small, tiny, tiny thing, and then a massive explosion of anger. And we tend to see it go from rage to remorse. It does affect their relationships with other people. It does affect their physical health, right? Anger, high levels of anger leads to high levels of hypertension, diabetes. We may have a lot of problems regulating emotions. We do see physical changes, higher than normal levels of inflammatory markers, which then facilitate aggression. Again, higher levels of testosterone in those with intermittent explosive disorder. Um, Exposure to violence at a young age, you're more likely to have intermittent explosive disorder. Childhood sexual abuse, higher likely of having intermittent explosive disorder. Common for families to have history of addiction and substance abuse. So we do see impulsivity and aggression as distinct characteristics. Treatment is hard. Therapy and psychopharmacology. We do have some off-label medications, SSRIs, antipsychotics, which can help. Oftentimes, right, parent management training, therapy, and honestly, sometimes with all of these patients, all the ones we've talked about today, safety, right? Meds, therapy, parent training, and if the kid is being dangerous, destructive, call 911. Um, and we kind of we'll watch in this class, and of course, it starts with the best caption ever. This kid has IED, mom tells him no or something, and he just starts raging, especially when we get to these older teens. If they are violent, if they're being aggressive, we might not, as parents, be able to handle it on our own. And sometimes we just have to let the parents know it's okay to call 911 if you need help. Um, we have some different scales that we can do. We can see scales for ODD and conduct disorder. We might have some overlap in it, so we do have to be cautious. Suicide risk is a big one. Impulsivity is a huge risk factor for suicide. So if we have someone who is impulsive, we have to look at suicide. Drug and alcohol, not falling into treatment are all big things. Screening tools, that Vanderbilt assessment is one that also includes ODD and conduct disorder on there. So for kids, most of the time, that Vanderbilt includes all of them. Self-assessment, if you're working with someone with aggression who's just yelling at you and being really mean, it can be hard. So sometimes we need to take care of ourselves and take a step back. That's the biggest thing on self-assessment. Interventions, safety, right, for that patient and for everyone else in the unit. We want to establish a rapport because we want the child, that patient, whoever it is, to talk to us. Set limits. If the answer is no, the answer is no. We can't give in. And that is kind of one of the hardest parts about it. We need consistency even amongst different shifts, amongst different teams. If we set a rule, if we set an expectation, we then need to follow through on it. You can't do X, Y, and Z, right? And we need to explain. Let's make sure they know beforehand. We can't just retroactively go and punish someone. Especially with our impulse control disorders. Confusion can lead to aggression. Structure, boundaries are wonderful things. No is a complete sentence. But we do need to make sure that they understand why the rules. When I worked with pediatric patients, one of the hardest things was in the summer. We had a pool and we could take the kids swimming. And especially our more impulsive kids, it was hard. So we had like concrete rules. If we were going to the pool at 2 o'clock, any unsafe behavior after 11 a.m. would mean you'd have to sit out on the pool. And everyone knew that from the beginning, and we stuck to it. Because if we didn't, well, why did he have to do this? And it just got complicated. Treatment for all is individual, group, and family. We need to attack right every area. Structure, teach the family how to set limits. Meds are going to be right up in the air based on what is going on. So when we talk about managing disruptive behavior, we have a bunch of different things that we can do. I have pulled out box 21.1 in your textbook. This kind of goes over what they are. It's like a behavioral contract. We explain what the rewards, what the consequences are from the beginning. Modeling is a good one. We show appropriate behaviors, so the children copy our behaviors. Planned ignoring. If the behavior, right, is attention seeking, and it's very weird because when it says not to be safe. So a good example, and I know it's very weird phrasing. If I had and actually I did, true story, I had a young kid, he was like 6, and I'm in the nurse's station with the door closed, and he is just banging on that door, right? And he's trying to break the door down. I'm gonna effing kill you. I'm gonna kill your family. He threatened everyone, my dog, my neighbors, all of my mom, my dad, my kids, everyone. And he just sat there. So I ignored him, right? Trying to beat the door down, all of this stuff. It was iffy, right? He was being unsafe, but he wasn't a danger to himself. If I would have walked out and tried to have a conversation with him, it would not have gone very well. So I planned to purposely ignore this kid. I sat in the nurse's station. I did not give him any attention. Once he kind of was able to calm himself down and he sat down, then we could have that conversation about what was going on. But in that moment, I was not going out there and talking to him would have done no good. We want to keep our distance. We don't want to get close. Redirection, and this goes even for like our ADHD type kid, depending on what's going on. If there's an undesirable behavior, we can try to redirect them into an appropriate activity. If they're doing something good, right, give attention. These kids often don't receive positive feedback, so positive feedback can over time go a long way. Clarification, that kind of is making sure we know what the rules are, so there's no misunderstandings. If there's room for confusion and then there are consequences, that can cause someone to blow out. And that's true for most of us, even as adults. Changing the activity, right? Basketball, not the best activity for someone who is easily frustrated. Making sure we know what our limits are. No is a complete sentence. I'm going to skip restitution. If you hurt someone, if you break something, you got to make it up to them. And physical restraints, hopefully seclusion is a last resort. And that is going to end this slide. If y'all have any questions, please let me know.